Great, thank you very much. It's great to be at a conference where they're actually having to put chairs in because there's so many people here. You normally feel like you're addressing the 3 people who are sitting on something. It's obviously a very popular conference, so I'm delighted to have been invited to speak. And I'm just going to try and zap through a bit of an update on where the regulator's at, which is what I've been asked to do. So, in essence, what we've set out to do, we're still very, very new as a regulator, as I keep reminding everybody. We try and look at the outcomes and people's experience of care, and our entire regulatory model is based on that desire really to focus on outcomes for patients and service users and what their own experience of care is, and use that as a bedrock for our judgment as a regulator. So we therefore try and involve people who use services both in planning for how we conduct our work, in actually carrying out inspections of our work, but critically, of course, in talking to people who are in receipt of care about what their experience of care is like when we're making our regulatory judgments. We use a wide range of information and analysis in order to make that judgment, and I'll say a little bit more about that as we go along. We absolutely are focused on how care is delivered, not on the processes and inputs and systems around it. We do our best to take very swift action where we see that care is poor. So within the legal constraints within which we work, we act quickly to remedy poor care. And all our inspections are unannounced. So we've recommitted ourselves to a process of unannounced inspections. Again, I'll say a little bit more about that as we go along. But that's the essence of what we do. So what people want a regulator to do is get out there, get the boots on the ground and see what the quality of care is like from the perspective of patients and service users. And that's what we spend our time doing. So a little bit, therefore, about what we've seen so far and what's happening across the health and social care spectrum at the moment. Well, you don't need me to remind you that the biggest challenge in the health service, not least, I know that Professor Field is going to be talking about the reform, so I wouldn't dream of saying anything about that. But, of course, beyond the changes to commissioning and the engagement of new system regulator in the form of monitor, the biggest issue facing the NHS is, of course, the financial challenges that it's currently facing. Within that, nevertheless, £1 billion has been put aside to look at integration of health and social care, which remains one of the largest challenges for the sector, I think. In social care, what we're seeing, what CQC is seeing, is the consolidation of the market, so larger corporate providers taking over increasingly in the market. The impact of personalisation on social care providers, so 340,000 people now have access to personalised budgets. And it's estimated that about just over a third now of social care is self-funded. Future funding, well, the future funding challenges in social care, again, we're all very familiar. Will the Dilnot recommendations or a version of that be implemented? What impact is that going to have on social care provision? And again, from our point of view, as we see people taking more control of their own budgets and personalisation and self-funding coming in, we're seeing a growth in unregulated aspects of the market. So personal assistance, care at home is increasingly moving from home care agencies to people employing their own personal assistants. So these are unregulated provision of services. Is that a good or a bad thing? That will bring huge advantages to providers, but of course, to service users, sorry, but of course brings risks as well with it. For CQC, very few of the changes that are going on in the landscape of health and social care are directly affecting us. The coalition government recommitted themselves to CQC as a regulator. We're now, or on the 1st of April, we will be 3 years old as a regulator. That's longer than any regulator has survived so far. So we've got brownie points for survival, if nothing else, at this point. We will be taking on additional responsibilities through the creation of Health Watch England, which will be a national consumer champion body that's being created within the Care Quality Commission, so it will become an element of CQC, but of course obviously the main driver for Health Watch will be local Health Watch bodies, which will be a separate entity. So we will just look after that legal body that oversees local health watches. I think the other thing that we're trying to do now is understand a bit more about what the quality interface will be for us. So we in terms of NHS regulation, we've got quite detailed relationships with strategic health authorities and with primary care trusts, but of course we're very interested in how we can interface with the new clinical commissioning groups, how we can make our information about quality available to them, but also more particularly how we can get information from those groups about what their understanding of the quality of local services that they're commissioning from is. So it's very important for us that dialogue that's been a critical point of us establishing CQC in a very open, we've had a sort of open book policy towards the commissioners and the strategic health authorities, so they were aware of what we knew about the quality of services, that gets translated into links with clinical commissioning groups and whatever local officers the NHS Commissioning Board has, so that there aren't gaps in the system opening up between what we know and what the commissioners know. The coalition government have proposed that we take on some new responsibilities, Human Fertilisation and Embryology Authority, the Human Tissue Authority and the National Information Governance Board, but that will require additional legislation, and it's not entirely clear, particularly on the HFEA and the Human Tissue Authority, about what the timescale for that might be. So at the moment we're focusing on getting CQC up and running still, and the development of Health Watch England are the main structural changes for us that the new legislation's brought. So the regulatory landscape remains complex. Within the health service particularly, we've worked hard to establish relationships with both Monitor as a system regulator, obviously currently for Foundation Trust, but moving to have a wider brief. So there's still a piece of work to be done about what the organisations that monitor license in the new system and what the scope of that will be. So Monitor will be shifting from just being the regulator of a sort of high-performing group of foundation trusts to a body that licenses a range of providers of health services. So what the scope of that will be and how joint licensing with CQC will work as part of that landscape is yet to be worked through. We've also worked hard with Monitor and indeed with the commissioning bodies to look at how we will work with failing organisations when CQC identifies that there's system failure within an organisation, that the problems that an organisation is facing, and again specifically here talking about the NHS, are not just about how you get right a particular service, but whether there are real structural problems in how services are organised, or the governance systems that an organisation has to promote high quality care. Then we work hard to make sure that our efforts are aligned with Monitor, and that's been a big piece of work for us. And similarly, at the other end of the scale with NICE, we try and make sure that when we are making regulatory judgments and we're looking to establish what good practice in specific areas is, that we go to existing clinical guidance as published by NICE, as published by Sky, and as those two organisations come together, so that we're not inventing new clinical standards, but that we are going to the detailed standards that are provided by organisations like NICE. So if we're looking at A&E or we're looking at maternity services, we have general outcomes that we look at for all services. If we're trying to drill down into a particular service, we link to NICE and NICE standards so that we can understand what an industry standard should look like, rather than sort of inventing our own. So it is a complex pattern of regulation, but one over the course of the last 3 years we've been working through, particularly with NICE and with Monitor, to make sure that our systems are as seamless as they can be, and that we aren't duplicating one another's efforts, or we're not inventing different sorts of clinical standards to the ones that NICE are promoting, for example. The sector is, from our point of view, the regulatory sector is enormous. We're about, this time next year, we will be on the verge of registering 10,000 primary medical service providers, so GP services. We've registered 10,000 dental practices, 2,500 independent healthcare practices, adult social care services in 25,000 locations, 2,300 locations for NHS Trust. So we're currently regulating services in about 40,000 separate locations. Once GPs come in for the 1st of April next year to be 50,000 locations. So it's a big sector that we've been trying to introduce to this new model of regulation. As I say, one that's based on outcomes for patients and people who use services. So it's a different regulatory model, even for the independent healthcare sector and for adult social care, who were accustomed to being regulated before. It's a completely different model for the NHS that has never been required to meet legal standards and had a regulator who can then take action against them if they don't meet those standards. So it's the scale of registration and regulatory care is regulated care is a big one, but it's been a big turnaround for the sector to come to terms with this different way of doing things, and it's been a challenge for us as well, merging 3 organisations and bringing this really significant sector into a new era of regulation and a new era of quality assurance. So this is, you'll see, now I know all this is going to be posted on YouTube and you'll get it on your email and all the other modern things that happen this day and age. You don't need me to go through this, but what I wanted to do is just give you something about the scale of overall compliance. So, as you can see, we've looked at, so far, we've carried out, under the new legislation, we've carried out reviews of as you can see, in excess of 11,000 organisations. About 3,000 of those have been found to be non-compliant in some way. And that tiny sliver of 134 organisations where we have our concerns about non-compliance are so great that we've taken enforcement action against them. So that's the overall picture. You can see how that splits between the different sectors. Obviously, social care is by far the biggest in terms of volume of providers. So we've looked at 10,000 social care providers, of whom almost 3,000, so you can see where the bulk of the work is, have been non-compliant. NHS organisations, 4 we've taken enforcement action against. Independent healthcare, and then primary dental care, we've already begun, although we only took on the regulation of primary dental care this time last year, we've now inspected about 15% of all dental surgeries. So we've begun the piece of work that's going to bring them into the new regulatory model. We have to keep reminding ourselves that registration is only the start of the journey. And again, you'll be able to look at these slides in more detail, but what I've then tried to do is show you a bit about where we are seeing non-compliance. What are the outcomes? What are the regulatory standards that we most commonly see and are not being met? So this is for acute care, and you'll see it's mainly in the management of medicines and the care and welfare of people who use services. And the care and welfare of people who use services is a big catch-all, but will include things like dignity, nutrition standards, so the essence of caring for people. Again, this was very much flagged up in the dignity and nutrition reviews that we did of the NHS that we published towards the end of last year. We are engaging in a second wave of that with NHS trusts later this year, and also 500 adult social care providers. We will also be conducting a dignity and nutrition inspection of those. So a big area of non-compliance. And as you can see as well, you might not be able to see it very clearly, but you'll see it when you look at your slide packs, that the NHS, independent healthcare sector is sort of more compliant than the NHS. So there's more problems in non-compliance in acute care in the NHS than on the independent healthcare sector. I know those two organisations aren't directly comparable, but that's broadly it. In mental health services, it's the opposite way round. The NHS is more compliant than the independent sector. And as you see, again, a biggest area of where we've got problems in compliance is around the management of medicines. Again, some in the care and welfare of people use services, more issues in staffing that we found in mental health services. Again, you can see the levels of compliance are very high, but a pattern of non-compliance is starting to emerge in different services. The other thing I'd just like to say about the market, again, it relates to what I was saying earlier, which is that the number of residential care homes is declining. You need me to finish. The number of residential care homes is declining. The number of home care agencies is going up. The number of nursing homes is going up as well. So you're starting to see already a different shape in the market. And this is about compliance in social care services. I will zap through the rest, but I think it's worth just looking at this in a bit of detail if you don't mind. So again, respecting and involving people who use services, the care and welfare, again, those essence of care things, and the management of medicines are the areas where we're starting to find most problems in compliance in the Act. When we're making judgments, essentially we look at three things. We look at information from people who use services and who work in them, so we have a dedicated whistleblowing line and we get a lot of contact from people who work in services, but also we encourage service users themselves to contact us and we get a lot of contact from service users. We analyse data from a range of sources and of course we go out and we conduct inspections, and the inspections are all focused on direct observation of care and talking to frontline staff, and basically that's just more information about the circumstances in which we conduct inspections. We have said we'll inspect on an unannounced basis every NHS organisation every year, every adult social care and independent healthcare provider every year, and dentists and GP surgeries every 2 years. I'll finish that. Just to remind you that we do have formal enforcement powers which begin in issuing warning notices and finish with prosecution of people who use provide services if they continue to fail to comply. So, my closing remarks, you'll be delighted to hear. The public put an enormous amount of faith in people who provide health and social care services, a fundamental responsibility for making sure that you're compliant with the health and social care legislation that CQC works with is the provider themselves and the individual member of staff who's providing care. The regulator can't be everywhere by any stretch of the imagination, and though we're committing ourselves to more unannounced inspections, we're heavily dependent on the public, on people who use services and people who work in those services to give us information about the quality of the care, either by talking to us or when we go and visit. But I think that what we all need is a culture that doesn't tolerate poor care, where people can talk openly and challenge one another about poor care, because poor care, the challenge to poor care begins within an organisation and with individual providers. It doesn't begin with the regulator. Nevertheless, we will play our part in improving the quality of care, and I hope by the information I've been able to give you today, I've demonstrated that we're starting to use this really important piece of legislation to do that. Thank you.